Evening, everybody, and I'm really happy to have everybody back on the webinar. That is the Asian Pacific Geriatric Oncology Society webinar. We have this webinars usually monthly. We obviously and I welcome, of course, everybody who's joined us, and most importantly, I welcome our very esteemed speaker, that is Dr. Hemant Malhotra sir. We wanted to touch upon hematological malignancies, which I thought I have actually heard, sir, in a lot of at different forums, including Chai for Cancer and also uh, in conferences. And it's a great honor for me to actually hear him on this webinar. So, Hemant, sir, I mean, anything I say about you is going to be less only. But all I can say is, you have been really not only have you done what you have done as far as for patients is concerned, but you have had a huge role in mentoring so many oncologists, and we are very very happy to have you here. Wherein we know that you have created the necessary human resource which is needed for the unfortunate cancer patients. So thank you, sir. The floor is all yours.
Thank you so much, Prem. My very good evening and namaskar to all my friends and colleagues. And I think Prem is just too kind. I don't deserve the words he's just said, but really happy to be part of this webinar and contribute. And one huge positive input from my side is that we now have a full-time geriatrician at our institution, and we are really looking forward to taking our geriatric oncology to the next level. So, and I think, and I'll, kind of emphasize that in my talk also, that every single comprehensive cancer center is incomplete if you do not have a geriatric oncology unit. And some of the reasons why I say this, I'll try and elaborate on the 15-20 minutes I have. I mean, I'm not going to go into the details of management of the hematological malignancies. I'm just going to broadly touch upon some of the key issues, maybe one slide per hematological malignancy only, and some other general topics in the sense that why geriatric oncology is important. So here goes. My brief today is hematological malignancies in older adults, treatment and challenges. To introduce the topic and to highlight the clinical relevance to you, all of us should be aware that the prevalence of this combination, hematological cancers and elderly people, is increasing. And we know that hematological malignancies form approximately 10% of cancers globally. And because our population world over and also in our country is rapidly increasing, we expect more and more patients of this combination, blood cancers in the elderly. And why is this important? It is quite complex to treat these patients and quite clinically challenging because older adults, as all of you would know, they have a whole bunch of comorbidities. They are on lots and lots of medications. Their symptoms are atypical. The diagnosis is difficult, and the treatment is, impacted by all these factors. And it is absolutely vital that we tailor our treatment in this group of patients, considering the physiological age, not the chronological age, which again I'll emphasize in my talk, the functional status of the patient, and the treatment goals. So if you look at demographics and age-linked incidence, over 60% of patients of acute myeloid leukemia and multiple myeloma occur in patients who are more than 65 years of age. And as the age increases, the incidence of these malignancies increase. And by 2050, individuals who are more than 65 years of age will nearly double, escalating the cancer demand in this group of people. And we are all aware, all of us have done clinical trials in the past. Very few older adults are represented or take part in clinical trials. So there are knowledge gaps. Level one evidence as to how you should treat blood cancers in the elderly is lacking. And most of the recommendations which we have are extrapolations of this and that. All of you would be aware that suppose I have a new molecule which I want to test, I will test it in the best possible population. I will not test it in children. I will not test it in older people. I would test it in, say, somebody from age 18 to 60. So that's why we have very few trials of new agents in the elderly population. And that is why we lack, strong level one evidence of the recommendations. So why does hematological cancers, why do the incidence increase in adults? Why is it more common in elderly? Because as age goes on, clonal hematopoiesis increases with age. And we know that this is a precursor to many myeloid malignancies. There is something known as immunosenescence. Our immune system, like the other systems of the body in old age, goes to sleep or becomes sluggish, and the immune surveillance is decreased. This facilitates tumor growth, and this also contributes to treatment unresponsiveness. Then bone marrow niche, which is a place where our normal hematopoietic cells reside and function and proliferate. This is dysregulated because of age, and there is consequent disruption of regulatory signals, and there is promotion of dysplasia, which again is a precursor to blood cancers. Now, what are the barriers to timely diagnosis of blood cancers in the elderly? Excuse me. First and foremost, the presentation in older adults is atypical, and many times it is masked by aging and masked by other comorbid conditions. Then our elderly patients are taking multiple medications, and because of these medications and their side effects, it is difficult to pinpoint the symptoms of blood cancer and the symptoms is related to the multiple drugs and the combinations which these older patients are taking. Then because of the comorbidities and because of the underlying chronic diseases, again, the symptomatology is masked, the signs are masked, and this leads to delayed referral and delayed testing in these patients. So these are all the challenges in diagnosis: atypical presentation, polypharmacies and comorbidities, frailty and functional impairment, ageism and diagnostic delays. Ageism means that the family, as well as the general physicians, the patients, family practitioners, they label most of the most of the early symptoms to age-related symptoms and miss on the early diagnosis and miss on the symptoms of blood cancer. Then there are limited specialized multidisciplinary care centers, and there is a whole bunch of communication barriers. You have an elderly patient who has difficulty in hearing, who has difficulty in understanding, and asking the patient to then understand about the disease and make treatment-related choices is quite challenging. And there are several challenges related to management. Some of these are age specific. A few of them are listed here on this slide. Aging is associated with the decline in hepatic volume and hepatic blood flow. And as a consequence, drug metabolism and elimination is slowed. And as a consequence, toxicities of doses of drugs are much more. or the chances of toxicities are much more. There is decreased renal reserve, again leading to delayed clearances. There is increased risk of effect on the heart, the vascular system, and this leads to loss of muscle mass, which again increases the morbidities and further deteriorates the functional status of the patient. Other challenges in management include treatment toxicities and tolerances. There is always higher incidence of adverse effects in the elderly population. Even though several geriatric tools are available, I'll list those in the subsequent slides. There is very limited use of the geriatric assessment tools. There is a gross deficiency of geriatricians, and even at places where geriatricians are there, there is lack of cooperation and lack of working together between oncology centers and the geriatric departments. But basically, like we need several more PRAMs, and I wish we could clone PRAM and have one PRAM available at each of our large cancer centers. Then I already mentioned there is unrepresentation or underrepresentation of elderly in clinical trials. Older adults are rarely included in clinical trials, and a consequence you have, less of level one evidences. Then there are competing risks and comorbidities, and as already mentioned, the patient is taking multiple drugs, and drug interaction and the chance of serious adverse events also is contributing to the challenges in management. And of course, you have logistic issues like support limitations, issues of cost, issues of transport. This is particularly applicable in the West, where the elderly is expected to live and survive and thrive on his own. A little less of a problem in our country. So there are different needs for patients with cancer at different ages, and you would understand that. For the young patient, more aggressive treatment is given. There are more responsibilities which the patient has. Our goal is to increase the lifespan, and it is mainly curative. Now, on the other hand, in the older patient who is more than 65 years of age, our goal many times is to increase the remaining quantity of life, but maintain that quality of life. And many times, in addition to the goal of curing the cancer, we also keep in mind that, okay, let's palliate this patient, let's maintain his quality of life for as long as possible. And that leads to alternative regimes, metronomic treatments, reduced doses of drugs, and some specific combinations which are more aimed at controlling the disease rather than curing the disease. So this difference in the basic goal, in the basic approach in patients of cancer, whether they are young or whether they are old, is significantly there. Say, for example, we wrote this editorial in the Cancer Research Statistics and Treatment sometimes in 2023. Outcomes in patients with multiple myeloma, does age really matter? And we'll try and answer this question in some of the subsequent slides. Is age the whole story? And here is the big question that is chronological age everything, or is there something like functional age? You will recognize this gentleman, the omnipresent hero of South Indian films, Mr. Rajnikant, is still active and still commands a huge following. So most of us do believe that chronological age is not equal to biological age, and functional age is something which is more important when you decide the intensity of treatment, the goals of treatment in the elderly patient. So geriatric assessment is extremely important in every single elderly patient. And this is important because you have to stratify the fitness to the tailored intervention. And this is just not chronological age. You could have a fit 80 years old, and you could have a frail 65 years old. And to make you and to help you decide this, a lot of tools, the validated tools are available in practice. The G8, the CARG, the IMWG Frailty Index, which will decide if the patient is fit, if the patient is frail, should the patient be given aggressive treatment, should the patient be given a low intensity treatment. All these will be decided by these tools. So I'll just list the tools very briefly. Maybe more details can come out during the panel discussion. The CGA, or the Comprehensive Geriatric Assessment, is our most detailed tool. This focuses on the frail older adults. These are some of the dimensions which are looked at, but it takes a lot of time, and there are very few centers which are able to do this. So there are other validated scores and scales which have been developed. The VES 13 scale, a snapshot of that is shown here. 12 items are assessed, and a score is assigned to the vulnerability of the patient. Then there is the G8 scale, which I think is the most popularly used scale, even in non-geriatric driven oncology centers. And this has a reasonable sensitivity and a reasonable specificity. Then the crash score chemotherapy risk assessment scale for high age patients, and the CARG score, cancer and aging research group score. These are some of the other tools which are available to us to objectively identify and define frailty. And most of these tools have been proven to be superior to the Karnofsky performance status, which we use on a daily basis. So basically, for the older adults, you have to balance efficacy, tolerance, and the goals of treatment. And risk-adapted protocols are usually chosen. There is a preference for oral agents, most or best exemplified by the use of venetoclax in acute myeloid leukemia, because you reduce the hospitalization and you enhance the treatment addition. And you also have to integrate palliative care right at the beginning of treatment, rather than at the time where your chemotherapy goals have failed. So these are the few common hematological cancers which are seen in the elderly: chronic myeloid leukemia, acute myeloid leukemia, non-Hodgkin's lymphoma, both high grade and low grade, like both high grade and follicular. Hodgkin's lymphoma can also be seen in the elderly, and multiple myeloma is the most common disease which we see. The median age diagnosis is 70 years. So this is just a quick snapshot of a large study in Lancet in 2021. And you can see the median age at diagnosis of these various cancers. So you have to think of AML, CML, CLL, NHL, both DLBCL and follicular lymphomas, and of course myelomas, in which the median age presentation is 69 years. So now, very quick snapshot, just one slide per hematological malignancies, and I'll leave the detailed discussion to the panel discussion. High risk genetics is very commonly seen in AML, and TP53 mutations and complex karyotypes are most commonly seen. So this is an additional challenge when you are treating or working up an elderly AML. The toxicities of standard treatment, I think for a frail adult, it is just impossible to give intensive chemotherapies. The standard chemo, which we give induction chemo, 3 days of Dono, 7 days of Aracy, is hardly ever possible in the elderly. So the intensity of treatment is usually decreased, and targeted low intensity options are usually chosen. And we now have a very effective regime, which is not very toxic, and it is quite effective, producing a CR rate, even in the bad cytogenetics group of elderly patients, of about 50 to 60%. And most of us have shifted to this combination of venetoclax and a hypomethylating agent in frail, elderly, acute myeloid leukemia patients. Now, what about chronic lymphatic leukemia? This is usually a age. This is usually a disease of older people. The median age of diagnosis, at least in the West, is 70 years, and the choice of treatment very heavily relies on the comorbidity and the risk assessment. Targeted treatments, particularly oral treatments like the Bruton tyrosine kinase inhibitors, either ibrutinib or acylabrutinib, in combination with venetoclax or in combination with the anti-CD20 monoclonal antibody, has replaced chemotherapy in most settings. And a fixed duration approach, like the combination of venetoclax and anti-CD20 monoclonal antibody for 1 or 2 years, is also an approach which is very often selected for patients of CLL. Non-Hodgkin's lymphoma, again, particularly the low-grade lymphomas increase as in age increases, but aggressive lymphomas are also seen in the elderly. And then there is a frailty tailored regimes which are available, dose modified R-CHOP, or what we call as R-mini CHOP, is one of the popular regimes. So rather than use full doses of doxorubicin, you introduce a new agent, etoposide, in many of these regimes. And your goal is to produce a remission rather than a cure. Of course, there is a big role of monoclonal antibodies and targeted approaches, anti-CD20 monoclonal antibodies like rituximab, CAR T cells, lenalidomide with rituximab, the R2 regime as they call it. These are some of the approaches which you take in older patients with non-Hodgkin's lymphoma. Multiple myeloma, again, a cancer of the elderly, median age of diagnosis 70 years, and if you give them full-blown treatment as you would give a younger patient, there is disproportionate toxicity. Hardly any of these patients, and very, very few patients above age 65, are candidates for transplant. So you have to choose regimes which are appropriate for transplant. Ineligible patients, you would have a rare patient in which you would say a 70-year-old or more than 70 years of age, in whom you would think of a transplant up front. The International Myeloma Working Group has devised a specific score which assesses frailty in patients of multiple myeloma, and this will guide you as to the choice of treatment. What are the innovations which are happening in this group of patients? Novel targeted therapies like the bispecific antibodies, venetoclax combinations, BTK inhibitors are some of the modalities which have been used. CAR T cell therapy is again quite possible and feasible in elderly patients. In fact, the first CAR T which we gave to a patient of relapsed high-grade lymphoma at my center was 80 years of age, and she still remains the oldest patient on the Indian CAR. And then gerotherapeutic strategies are evolving, and we are trying to offer the best possible treatment to our elderly patients also. This issue, the representation of older patients in clinical trials, people are also thinking about this, and certain reforms and rethinking by the ethics committees and the scientific committees is now happening. And maybe in the near future, we will see more and more trials with elderly patients. Survivorship in elderly is again extremely important as in the young. Late treatment effects have to be monitored. Multidisciplinary support and integration of oncology, geriatrics, palliative medicine, rehabilitative services is extremely important. Big role of integrating psycho-oncology and psychosocial experts into your treatment paradigm is again something which needs to be done and which should be done. more and more guidelines specific to the elderly patients with blood cancers from the ASH, from the NCCN, and the myeloma working group are now available to us, which help us in accurately tailoring our treatment to our older patients. So geriatric oncology integration, geriatricians and oncologists and need to be on the same page, need to work together, need to assess these patients together. And my personal opinion, a geriatric oncology unit should be made mandatory for all comprehensive cancer centers. And we should join with the geriatricians in fine tuning precision oncology and personalized treatment, which is tailored to the frailty of our elderly patients. And of course, research goals should be there, and next generation trials in the elderly is the need of the hour, which I hope will happen in the near future. With that, I'd like to thank you very much, and I'd like to hand over proceedings back to Prem, and maybe we can do the questions in the panel discussion. And my apologies if I went a few minutes over time. Over to you, Prem. Thank you very much.
No, thank you. Thank you, sir. That was a very eloquent and to the point presentations in which you highlighted pointers on every type of cancer and also in general how geriatric oncology should work. I am sure the task was difficult, but you have, as expected, put it very precisely and covered all points. Yes, we will take questions, but we'll take questions at the end of the panel discussion. Let me introduce you to our moderator of the panel. It's Dr. Tilak. Welcome, sir.
Thank you, Dr. Prem.
Yeah, I give the forum to you to just introduce the panelists. Thank
So,
you.
Prem, I may add that Tilak is the Air Commodore now. Is that right, Tilak? Am I correct?
Yes, sir. Yes, sir.
So, like, salutations to you and all the armed forces of the country.
Thank you. Thank you so much, sir. Thank you, Dr. Prem, for the invitation. And it's always a pleasure to be on a stage or a panel with Dr. Hemant Malhotra on it. Sir, you've been a guide, a philosopher, a senior, and more importantly, how you come across as a nice friend. It's a pleasure to interact with you, sir. And one thing our audience must have noticed, and has been the characteristic of Dr. Hemant Malhotra's presentations, is the tricolor flag, which is there on every slide. It's really proud to see that, and the way you have it in almost every presentation at every event. Sir. It's great. Sir.
That's my USP, Tilak.
Absolutely. So we see the slide and we know this must be Dr. Hemant Malhotra's slide. Thank you, sir. Very lucidly, you brought about the challenges, the roadblocks, the ways to handle hematological malignancies in the elderly. I shall now introduce our panel. Of course, Dr. Hemant Malhotra is there, senior medical oncologist from Jaipur. We have Dr. Alok Shetty, consultant medical oncologist from Mumbai. And we have Dr. Anupama, a consultant geriatrician from Chennai. So with the permission of the organizers, may I share my slides? So I have kept a very unusual case, although the same hematological malignancy, yes, but the primary is something different, mainly because these are the cases where we've had a lot of difficulty in managing them, especially in the elderly population. So once again, welcome to our panelists. And I shall go on with the case. So I will present the case initially. I have a few images of this case which we worked up at our center. And then we'll discuss the various geriatric issues as well as the oncological management issues of this case. Is Dr. Anupama online? I don't see her right now.
Sir, good evening, sir. I'm here.
Oh, right. Hello, ma'am. There you are.
Yes, sir. Good evening.
Welcome.
Yes, sir.
Right.
Thank you, sir. I'm listening.
Right. Great. So looking forward to a nice discussion with all of you. So this is a 70-year-old male He lives alone in a single-story home. He's widowed, but his sons are there to help him around. He's a hypertensive, diabetic, has got osteoarthritis. He has benign prostatic hyperplasia, some mild cognitive impairment diagnosed a couple of years ago, and history of falls, 2 episodes in the last 6 months with no fractures though. And he presented with progressive confusion of about 3 weeks duration. And his son reports that he has been more forgetful, occasionally disoriented to time and place, and has difficulty in finding words. With some unsteady gait and weakness of the left side, some new onset headaches, and he also complains of intermittent blurred vision and an episode of urinary incontinence. No history of either major trauma, fever, or recent infections. He's otherwise a retired school teacher, former smoker, minimal alcohol consumption, and limited mobility due to osteoarthritis, and uses a cane. This is the medication history on which he is on for his various comorbidities, antidiabetics, antihypertensives for the BPH, donepezil for his MCI, and he takes paracetamol as and when needed. On examination, is an elderly gentleman, alert but disoriented to time. He appears frail with slow movements. His vitals are by and large okay, mild rise in systolic BP. And neurologically, his GCS is 14/15. His MMSE is slightly reduced. It was earlier 26/30, now it's 22. Some blurred vision in the left visual field and an upper motor neuron weakness in the left lower limb and upper limb. He's got an ataxic gait and his sensory system is intact. Other systems are normal. The musculoskeletal system shows limited range of motion. In the geriatric assessment, he meets the criteria for frailty. He has a high fall risk. The timed up and go test was done, though he's got weakness, so this may not be actually applicable. And he's got 5 medications qualifying for polypharmacy. He was evaluated. His biochemical parameters were hematological parameters by and large normal, except for a raised creatinine of 1.3, marginally raised. And CT scan of the brain revealed a hypotension in left parietal lobe, and MRI of the brain also revealed the similar lesion, 3 centimeter enhancing mass. I've got some videos of the lesion. You can see the large edema and the mass in the frontoparietal and temporal lobe involvement. And similarly in the this is the other scan showing a different view, the coronal view showing the sagittal showing lesion, mainly the temporal and parietal lobe, and involving a lot of edema. So he underwent a stereotactic brain biopsy, and it turned out to be a high-grade B-cell primary CNS lymphoma. His PET scan was also done for a extracranial disease. There was no disease elsewhere. His HIV was negative, and ophthalmology reviewed a right homonymous hemianopia and a normal fundus examination. There was no involvement of the eyes. So here we have an elderly male, 70 years old, known hypertensive, diabetic, BPH, some mild cognitive impairment and osteoarthritis, who has presented with features suggestive of a intracranial space occupying lesion, was diagnosed as a primary CNS lymphoma. We'll start with Dr. Anupama. As regards these kind of patients, when they come to your clinic, how do you go about assessing the frailty and the fall risk? What are the scores which you use? And as it's more like since we have postgraduates on the line, so how would you go about these cases?
Regarding frailty, usually here in our hospital, we do the clinical frailty scales. So we scale, yes. So accordingly, whether he is terminally ill or very severely frail or severely frail, moderately frail, mild, vulnerable, managing well, or very fit. So once this has happened, then we assess them for the fall risk. usually just a simple question. Have you ever fallen in the past 1 year? And then regarding the scores, we either do the performance-oriented mobility assessment, wherein both the balance as well as the gait is assessed.
That is the short performance battery. That's what you mean?
Yes, sir. Yes, sir.
Yes.
Then the other tests also, which are requiring very less time, is the tug test, stand up and go test, functional reach test, the Berg balance scale.
Yes.
So,
and the Edmonton frailty scale. And of course, there are many scales available.
Yes, sir.
But I think every institution has its own way of assessing DT.
Yes, sir.
So we do use the tug test quite often. And in fact, while I was at my previous place in Pune, we had obtained that machine called the Q-Tug. And we had this study on patients before chemotherapy and 3 cycles after chemotherapy, almost 256 patients. And we actually found some interesting results with respect to the tug timings. Our resident, in fact, recently presented this paper at the ASCO in 2025 at Chicago. So these things actually give us a very objective view of assessing a person's risk of fall, isn't it? Dr. Prem, what about you? How do you utilize these scales in your clinic?
I would say yes. Most of the things that Anupama ma'am has said is there, but tug is something which is done routinely. One is because it's pretty much doable, and secondly, it does not require very difficult thing in actually making the person also understand. So I think if of course if there is a dearth of space, then you might have to just go for pure scales. But I feel tug as a test really gives you a lot. And even for postgraduates, and I think knowing how to do a tug, I think is very good. And of course, you mentioned Q tug. I think that is one of the most revolutionary things that has actually happened with tug. In fact, yes, of course, AFMC has given a significant number of, which you mentioned, significant number of data as well. And I think that helps us in knowing that the dual tasking also. So I think tag would be the best. And it helps in actually dealing with both. So it's like and it tells us a lot of more things. So it's quite, I mean, you hit the nail on the head with a single arrow. Yeah.
True. I agree with you. I mean, the very fact that you have to get up from a chair, walk, turn around, come back, that gives a lot of clues. So the second point this patient, of course, is polypharmacy. So Dr. Anupama, how do you proactively handle this issue in geriatric oncology patients?
Sir, I would take into account whether there is any loss of appetite, and I would try to apply Beer's criteria as well and see if there are any drugs which are actually contraindicated while given as a polypharmacy. If they are life-saving medication, then I would prefer to continue it. Yes, sir.
Right. So one thing which I'm talking as an oncologist who's now going into geriatric oncology, something which I learned, which I probably never realized the importance, was the brown bag review, they call it. You know, hello?
Yes, sir.
Am I audible?
Yes, sir.
Yeah. You tell the patient to bring their bag of medicines and they put every medicine on your table. You can actually make out what he's having and how he's having it. It actually makes a lot of difference. Of course, the paucity of time during OPDs is an issue. But there is this one odd patient who comes with a bag full of medicines, and they really need to be, what should I say, reconciled properly so that this issue is. So, of course, this patient also has cognitive impairment already pre-existing and now has worsened because of the primary illness. So this will be a challenge for a single male who's living without a partner, has got only his sons to support him. So, do you routinely use cognitive enhancers in geriatric practice or geriatric oncology practice?
Sir, usually we are giving, sir. Once
Okay.
we come to a tentative diagnosis of dementia, sir, I am a community geriatrician, so I only do home visits, sir. So I do not ask them to get the MRI brain or any big thing stepping out of the house. I just write it there and put it as optional. Like if you can do it. Otherwise, it is okay. We will go ahead with a blood evaluation. And I also apply the scales for like the mini cog test to start with. And then I do the MOCA. I apply the questionnaire. And then of course, before this, I have to rule out the other causes as well. So the first thing is, again, the polypharmacy and his cognition, how it is. And then once I come to the tentative diagnosis that he has any cognitive impairment, I explain clearly that it may or may not improve because I haven't even made the diagnosis of actually dementia. Moreover, what type of dementia? Was it just vascular or was it Alzheimer's? So, of course, clinically, I do tell them to a certain extent this could be Alzheimer's, but then we can never be sure. So, with the concurrence of, yes, sir.
Yeah, please.
Yes, sir. So, with the concurrence of the caregiver support, whether it is the spouse or the children.
Hello, I think we just lost your. Can you hear us, ma'am? Right. I agree. Most of the times it's a clinical diagnosis. The imaging comes into play for exact delineation of whether it's a Lewy body disease, dementia, or Alzheimer's, etc. And of course, isolation is another issue we need to address in this patient. He's living alone. We need to address this part by giving some kind of a social support. And of course, his medications on which he's on for his comorbidities, they need to be looked into for his control when he start the treatment. There are other geriatric issues also which need to be looked into. But for the sake of discussion, it's mainly the frailty and fall risk, the cognitive impairment. There is history of incontinence. So the incontinence needs to be seen, what medications can interact, how the hydration during the treatment can affect his incontinence, etc. And that needs to be addressed. So coming to the oncological management, Dr. Alok, do you routinely use the geriatric assessment scales in your geriatric oncology practice? And if so, Dr. Hemant did mention some. Which ones do you use?
Yeah. So hi. So I mean, if we we send them to the geriatric oncology unit and they use most of the scales. I think G8 is what is commonly used. So yes, I mean, if some of our patients do go, and I mean, frankly speaking, not all because of some challenges. But if they do go, some of these patients do go for a comprehensive assessment. I mean, otherwise, only as part of a trial for patients of DLBCL, we have they're undergoing some geriatric assessment as part of a trial only.
Right. So in my practice also, I've realized that G8 is very easily doable, probably slightly more informative than VES. And Dr. Hemant, sir, any comments from your side on this?
I think this is the typical 80-year-old which we see day in, day out. And till I had a geriatrician on board, I mean, I used to desperately wish for a geriatrician. And you need to really truly sit down with the geriatrician and, you have to be on the same page and make joint decisions. And usually at my center, we also use the G8. And in patients in whom who need, kind of slightly aggressive treatment, we also use the crash sports. We find that also quite useful. We
True,
are,
true.
in
Agree,
fact,
sir.
one DM student of mine is doing a thesis on geriatric oncology, where she is comparing the All India Institute geriatric scale, the one which Joyita and her colleagues
Joyita.
have kind of designed with the standard other scales. And we are hoping to validate the AIMS score. I mean, that thesis is ongoing.
Oh, that's quite fantastic, sir. In fact, I was just going to mention that Dr. Joyita is online, and she's a dear colleague, both from the army as well as in geriatric oncology. And she did make this Scope C version 1, and it is under revision for version 2, maybe. So it's quite, I would should say, Indianized kind of a geriatric assessment scale. The questions are more pertaining to the Indian population whom we deal, as compared to the standard geriatric assessment scales. And I usually use the CARG scale, so like more than crash, maybe more of familiarity with it rather than any difference with the crash. But it does objectify how many agents do I use, single agent versus multi-agent, dose reduction, etc., in a more objective way. I'm sure you also realize that when you use crash, etc.
Yeah, correct.
So this patient with primary CNS lymphoma, the options among the various other options are rituximab, temozolomide, high-dose methotrexate, Rara-C, the RNPV, or a matrix regime. I guess the last two are very probably difficult to give in the elderly age group. Dr. Alok, what's your take on these protocols for primary CNS lymphoma?
Yeah, so any high dose methotrexate based option is going to be challenging in patients more than 65 years of age. So, I mean, we have given up to 60, 65. I mean, starting off with lower doses and then assessing the tolerance and deciding. I mean, one of the practice that we have at our center, I mean, for those who are elderly and we are planning for high dose methotrexate, we do a DTPA GFR. I mean, just to rather than just go by a Cockcroft-Gault equation. So that is one practice that we have at our center. But definitely at 70, 72, high dose methotrexate based options are challenging. So, I mean, one of the things is I think maybe rituximab temozolomide. The other option that we discuss in a lot of these patients is just whole brain RT with some IMiDs with lenalidomide is what we would currently give these patients. Yeah.
True, true. Agree. And even if you manage to give some high dose methotrexate to these patients, with even intermediate dose or whatever they can tolerate, I think consolidation radiation becomes a challenge with respect to the cognitive decline.
Yeah.
Do you agree?
Yes.
I don't know. Most of my patients have not been able to give consolidation RT beyond 70, 75.
Yeah. I mean, it is quite, I mean, the giving the high dose methotrexate itself would be quite challenging. And RT beyond that again is going to be challenging. I mean, we should probably discuss with the family and that this is going to be a little palliative therapy. And we're just looking at prolonging life and comfort. Yeah.
Very true. And the elephant in the room, of course, is the caregiver burden. The amount of the suffering the caregiver has, it's probably very less often discussed in clinics. How often do we talk to the caregiver, especially the caregiver is an elderly himself, like an elderly spouse. We rarely discuss the issues which the caregiver has got. So that also becomes a challenge with these patients. Dr. Hemant sir and then Dr. Alok, do you usually routinely send these tissue blocks for NGS in your clinical practice?
So maybe I'll go to your first question, Tilak. The first thing which I would do is that I would have a heart-to-heart talk with the sons. And only if one of them is ready to move in with the father, or if they are ready to have the father move in with them, would I think of, little more than a disease control kind of strategy. So that is extremely important, and that is the first thing which I would do. I not recently, a couple of years back, had a 78-year-old Sardarni Exactly the same situation as you say, but she had a truly committed family. The son was, you know, completely involved in the treatment of the mother, and the daughter-in-law was completely involved. So I did give that lady rituximab and high-dose methotrexate and Araci. I'm very frightened of giving high-dose methotrexate. Reduced it a little bit and gave, but she tolerated 4 rounds of high-dose methotrexate like a breeze, zero
Wow.
toxicity. Well, of course, she didn't. She wasn't as bad as your theoretical case. Well, maybe 2 or 3 drugs and a little more mobile than our patient. But I think the most important prognostic factor in that patient and in my other patients are the attendants. So I have no
Yes.
qualms in saying that the number one prognostic factor, other than the disease biology, in India is the attendant. If you have a caring, understanding attendant, that trumps so many things. And
Very, very rightly put, sir.
suppose the son say that, no, we are busy with our lives and I have this commitment on that meeting and we can't move in with the father, or he can't move in with us, he doesn't get along with the wife, then I would be happy to give the patient either rituximab, temozolomide, or maybe len and temozolomide. And to your direct question, I normally don't send very extensive precision oncology investigations. So I would not send the NGS I would not send the biopsy block for NGS in this patient.
Yes, in this patient. Fair enough, sir. Pointing. But very rightly said, sir. So when I talk to my residents in clinic, I tell them same thing. When you say an elderly patient, ask for 4 questions. What was his pre-morbid cognitive status? Is he using any aids like hearing aid, walking aid, etc.? What is the social support? Yeah. And that's a very important question to ask. And of course, the mobility. Is he ambulant? Is he wheelchair bound? How was he? So this pre-morbid, these 4 questions gives a good idea of what to give extra to this patient from in addition to the pure therapeutic point of view. Dr. Anupama, any more views on this? I think Dr. Anupama's connection might be unstable. Okay, I think we're buying a lot of time. So one final question for Dr. Alok. The role of CAR T therapy in elderly patients. I mean, this is just one case, but suppose you have a 70-year-old DLBCL stage 3 treated, relapsed. Do you have experience or have you tried or?
Yeah, I mean, we've given CAR in some patients who are like 70, I mean, definitely 60 to 80 years of age.
Great.
I mean, there are definitely challenges in terms of cytopenias and infections, but manageable. I mean, because it's like definitely not a contraindication, unlike a transplant, which requires high-dose chemotherapy. So the conditioning is much manageable. Definitely there are challenges in terms of managing the cytopenias compared to in younger patients, but it's possible and it's doable.
Dr. Hemant, sir?
I actually agree with that. And we've done, as I mentioned during my talk, we've done
80-year-old.
80-year CAR-T with on a 80-year-old relapsed DLBCL. And
Wow.
it is just 12 months now, and she's in complete remission and up and
Fantastic,
about.
sir.
So it is very possible to do. And if you have a center which is experienced in doing CAR-Ts, then toxicities are quite manageable, and many times toxicities are very minimal, much less than what you have with chemotherapies. And as Dr. Alok mentioned, the induction regime, fluci, which we give, that produces more toxicity than the CAR-T per se. So certainly an option which should be considered.
Wow, so that's very encouraging. This thing that CAR T cell therapy. I don't know. I've never done a CAR T cell due to lack of it in our institute. But is there this cytokine release and all these things and ICANS and all this lesser in the elderly?
So again, we have a limited experience. There are several centers which have much more experience. And you know, I have Hansmukh on board if I have a cardio to do. And he and his team are a big, you know, source of support. We can call them anytime and we get accurate inputs. And I don't know where did that echo come from. But anyway,
Yeah.
but in the Indian car, particularly the IIT Tata Hospital car, the ICANS are very, very few, less than 5%. And both the patients and we've used, both did not have any ICANS, zero ICANS. But the cytokine release syndrome remains a problem, and you have to have a very high index of suspicion and be ready with your tocilizumab, and you know, and not hesitate in using it at the first sign.
Great. So this was about the discussion of a case which we're finding it challenging to treat right now. So we'll start with some closing remarks. Dr. Anupama, I like your concept of home-based geriatric care. So how often do you meet these geriatric oncology patients at home? I mean, are they routine or are they the community geriatrics? Ma'am, I think you're
Dr.
muted.
Anupama,
You
we
might need
can't
to
hear you.
unmute yourself.
I
But
think there
unmute
is
yourself.
some audio.
No, we can't hear you. Ma'am, can you hear us? We are not able to hear you.
I think, Madam, Dr. Anupma, I suggest that you disconnect and reconnect. We can't hear you. Then maybe we can have your.
Or come in the audio directly. So, Dr. Alok, some closing comments on management of geriatric oncology cases, and then finally with Dr. Hemant.
Yeah, so definitely challenging in terms of like how Dr. Hemant alluded to in the talk. Especially a lot of hematological malignancies require a lot of intensive therapies, maintaining dose intensity, which becomes a major challenge in the elderly. So it needs to be tapered according to their needs. And age is many times not a criteria by itself to not give. So a lot of other factors also needs to be looked into, and a comprehensive geriatric assessment will give an objective idea regarding what therapy we need to plan with discussion with the family members and the support. So that becomes important. So yeah.
Yeah, I think even transfusion, as simple as transfusion of blood and components in elderly is a challenge.
Yes.
When they come with hemoglobin of 6 or 5, and you need to give them platelets when platelets are low, it does become a challenge in the elderly. Yeah, right. Dr. Hemant, sir, some final words from you.
So I think treating elderly patients with cancer in general and blood cancers or hematological malignancies in particular is really challenging. And you need to individualize treatment for each single patient. And you need to have your geriatrician on board and have him contribute to decision making. I mean, not just do the score for you, ease out your time and burden, but listen to him and listen to his advice and follow his advice. But I still truly believe that in some hematological malignancies which show a good response, an attempt at providing good quality of life and prolonged disease control, if not cure, should be made. And again, the most important thing for me to decide aggressive treatment versus non-aggressive treatment is the level of social support and family support which the patient has. That is really truly crucial in the elderly patient. I mean, if you have a gentleman like this living alone, 6 drugs, two falls a month, a history of 2 falls a month, and the comorbidities which you describe, I would just give this patient Len plus rituximab, But if the patient, like the patient which I had, that sick lady, 76-year-old, but 100% committed family. I mean, I could dare to give high dose methotrexate, and she's now 2 years down the line post treatment. She's doing fine, and I mean, I almost decided not to treat that patient, and now I'm so happy that I did treat that patient. And this case of yours, Tilak, touches a big chord in me in the sense that about 5.5 years back, my mother died of brain tumor. She had a whole bunch of comorbidities, heart and diabetes and this and that. And me being an oncologist, I couldn't dare to treat her with the high dose methotrexate, and I still have nightmares and regrets and second thoughts whether what I did was right or not. So, like, this is very, very personal to me. Thank you.
My God. That's quite nice of you to share that. If I had known, I would not have presented this case. But,
No, that's okay. I've got over some conflicts which you have to deal with yourself. No? There's some questions on the chat box. Tilak, I wonder if you would take that, or maybe Prem would take that.
We can take
that. Yeah.
Yes, sir. Tell me, sir. So it says elderly patient with TP53 mutation or complex karyotype. How do you go about realistic treatment goals? So, Dr. Alok.
Yeah, so I mean, both CK and TP53 very bad outcomes, even in young patients with 2-year survival is like less than 20%. So I mean, if the patient, when we've had such patients, just so if they're extremely frail, a lot of infections at presentation, performance status is poor. Many times we discuss for palliation alone. Again, it's a discussion. So whether between palliation alone or azacitidine venetoclax, knowing that even with azacitidine venetoclax, outcomes are going to be guarded. So it's a discussion with the family regarding the outcomes and realistic expectations. In these patients, maybe many times just palliation is also an option that needs to be discussed.
Rightly said. I think the term here is the realistic treatment goals needs to be explained very in the beginning before you start saying that these are difficult ones. Mehak has got 3 questions. So the first one is how to balance the use of GCSF in elderly patients at higher risk of febrile neutropenia, but with comorbidities like heart failure. So, Hemant sir.
So, yeah, I mean, I would not, kind of hesitate if I'm giving a regime with the intent of curing the disease or getting the patient into remission. I would tend towards giving rather than not giving.
True. I think GCSF can be safely used in elderly with even with comorbidities, because febrile neutropenia is going to really bring them down.
Yeah,
prevention is more important.
So more, I think more reason to give them prophylactic GCSF when
absolutely. Yeah, and your bar would be much lower in giving PEG GCSF or GCSF in these patients.
True. So when as our dose modification in elderly AML patients with baseline cytopenias or borderline organ dysfunction, and for those responding to when as our indefinite therapy versus treatment-free interval or holiday. So anyone, Dr. Alok, and then Dr. Hemant.
So nothing specific for elderly per se. I mean, we should keep in mind that this study was basically done in the elderly people and people who are ineligible for induction. So nothing specific for elderly patients per se. It's many times it's an individual patient based, or maybe sometimes depends on the disease biology also and how sensitive they are to venetoclax. So nothing specific.
So I think she's asking about baseline cytopenias.
Yeah, the baseline cytopenias, I mean, one should remember is many times due to the disease per se. So for the baseline cytopenias, one wouldn't do a dose modification. Once the patient is in remission, then we attribute that cytopenia to venetoclax. So if the baseline cytopenias, I wouldn't suggest any dose modification. Unless, of course, if there is an underlying MDS, one may need to be careful. Again, they may be a little more sensitive to ven-induced cytopenias. So if there's an underlying MDS, maybe you would keep the duration of venetoclax a little shorter. But if the cytopenias is due to extensive marrow involvement and the disease, then that does not require a dose modification. And again, for organ dysfunction specifically, there is no reduction of venetoclax dose. The azoles, you may have to be careful if there is hepatic dysfunction. That's it. But for organ dysfunction, again, venetoclax or azacitidine does not require any dose modification. Regarding
more often than not, it's
sorry.
Yeah, go on. Regarding?
Again, regarding, I think the indefinitive therapy treatment-free interval, I think no data or recommendations. So the current recommendations are to continue it till patient is in remission. I mean, there are times when we have had this few patients who are elderly, NPM1 mutated, going on for 2 years or so, where we have had a discussion and stopped and just we are still monitoring. But otherwise, currently no recommendation for a treatment-free interval or a holiday in when as a patients.
Yeah, whatever they're tolerating, we try and continue for as long as it goes on. Hemant sir, practical approach to induction in elderly myeloma, doublet versus triplet, and maintenance, continuous versus fixed.
So I would be happy to do 2 drugs in the elderly, if provided, and if the frailty score is high and if there are lots of other meds. I mean, I rarely do doublet maintenance. I would be happy with 5 milligrams continuous len, or if the patient does tolerate 10 milligrams continuous len, certainly not dexamethasone and certainly not bortezomib in the maintenance, but low dose len. I'm very fond of len. That sometimes does control the disease for a few years.
Great. So this question for Dr. Anupama, if you're online, ma'am, what geriatric assessments are rational to apply in home care?
So can you hear now, sir?
Yes, now I can hear you.
Home care, actually, the first thing is functionally they're very frail, and that is why we get called to see them at home. Which means already most of them whom I see are bedbound, and they are totally dependent on caregiver for all activities of daily living. So in such type of patients, usually I find that removing the chemotherapy actually causes a improvement in function. So you were asking, like, have I seen any oncological patients at home? Yes, I have. The scenario would be like they are extremely frail and bedbound. So with absolutely no appetite, at least removing the drug, causes the appetite to pick up. And then they have some strength. Sometimes the function also improves, wherein they're able to walk with the help of assistive device and a physiotherapist.
Yeah, I tend to agree with you, especially in very frail moribund patients who are on because of the treatment. Sometimes peeling off the therapy also is actually a good palliative. Yeah.
Yes, I have many instances wherein after stopping all the chemotherapeutic drugs, and then the patient has lived for 2 to 3 years without them, with actually a reasonably better function, meaning they were able to walk outside of the house with assistive devices and had a reasonably good appetite and good cognition as well.
Yeah. And this reminds me of a case of CA ovary was on maintenance olaparib, and she had transfusions and admissions and cytopenias and GCSF. And finally, when she came to us with all these things, we realized just peel off the olaparib. Why does she require it? And she went on to live for a couple of years. Yeah, I tend to agree with you on that. And
the other thing you said was things going wrong when the patient comes with some kind of complaint. Because I regularly go home and see this lady. She was a case of bladder cancer. She has been treated and she is declared cancer-free. But then every year she would go to the oncologist for the review.
CPE, the endoscopy.
Yes, sir. And then I was called because the managing her diabetes and managing her hypertension. These were the comorbids. Functionally, she was managing well. Now, she just had only some headache. Now, this happened after she left to her son's home in Singapore. And I just, today morning only, the son called and he, usually they keep me informed. So they said that the headache is most probably the temporal cell arteritis. and because of which, whether to go for the biopsy and whether to start on the high dose steroids. I said, please do it because it has a very good prognosis. Otherwise, the visual problem is there. And then after a month, they have realized that it is because of the secondaries. So retroorbital secondaries and extensive secondaries all systemically everywhere. And now they have given up and they're planning to bring her back home, and they were asking if I would give some kind of valuation.
I think in any case, I think excluding secondaries becomes very important. So, Dr. Chaudhary's second question is quite a large area. It says routine oncology markers we can suggest in the geriatric age group. Hemant sir, routine oncology markers, routinely without any indication in elderly age group.
So like the usual screening guidelines which we follow for ladies, careful assessment of the breasts, maybe abdominal ultrasound, and for the males, regular checking up of the PSA levels and making sure that the patient is not developing, say, a colon. Somehow colonoscopies are not very popular in our country, but as a minimum, you could do the stool occult blood testing. Now there is a validated molecular test for colon cancer also. So if you have a patient who doesn't have any economic issues, every 3 to 5 years, that test could also be ordered. And just keeping your index of suspicion high and having a checkup sooner rather than later is probably the best advice you can give to your friends, elderly parents, whatever.
I agree with you, sir, but my take on this is slightly different in the sense that, I mean, most of these tests, like a CA-125 or a CEA, getting it done annually, without any high, pretest probability of it being high, you invariably get some false positives and they go on a wild goose chase and unnecessarily leads to problems. So I think, like you mentioned rightly, giving a good education to this age group, telling them what to look out for, which is unusual in them, and examining them thoroughly. A good clinical examination every year probably would be good enough for elderly patients.
Completely agreed.
Dr. Joyita says, was Donep indicated in this case? Yeah, I agree. 70 years. They felt it's too not actually indicated. I kind of this patient was treated donepezil outside, came to us with this. So 68 years starting donepezil just for some mild cognitive impairment may not have been required. So with that, we finish. I hand over back to Dr. Prem.
Hemant sir, you wanted to say something?
No, I think I just wanted to make a comment on this donepezil. If somebody elderly, the cognitive function is going down and you show to a geriatrician or to a physician, they sometimes feel, impelled to do something. And then, kuch to dena hai types, and then this phenomena happens. When my neurologist gave the same medication to my father for months and months. It didn't make any difference. But you know how things work sometimes.
Yeah, so just to follow up on that, I think in our practice, it's always good kabhi sochna ki kuch nahi denge to acha hai. So I think thanks a lot. I think the discussion was great. So thank you, Dr. Tilak, for moderating the session. I know what happened before the session, so that's great job. And thanks the panelists, Dr. Anupama. Thanks a lot to make time, and Alok as well.
Thank you, sir.
Hemant sir, thank you for guiding us as far as hematological malignancies was first, and also being a part of the panel. So thank you. And yes, it's been a long session, but I never felt like stopping it. So it's a good. I think it was a complete session. Thank you. Thanks a lot.
Thank you, Dr. Prem. I'll break the suspense of what Dr. Prem was saying. What happened before? I had prepared a case of urothelial cancer, bladder cancer, and when I opened the mail for seeing the link, I realized, oh my God, there's hematological cancers. So I took out my latest case which is under evaluation in a hospital. I quickly asked my resident to send me the videos of the MRI. So,
but you did a good job, Tilak, as you always do.
Thank you, and lovely discussion, sir, and nice deliberation. Thank you, Dr. Prem. Thank you, Dr. Anupama, Dr. Alok,
Yes, sir.
Dr. Hemant, sir.
Pleasure to be a part of this.
Thank you for all the
Have a wonderful weekend, guys. Thank you very much.
Thank you.
Thank
See
you,
you, sir.
Thank
Bye.
you, sir.
Bye bye.